You're lying on an operating table. The surgeon who's going to cut into your body isn't holding a scalpel. They're sitting at a console across the room, fingers in thimble-like controls, watching a 3D screen. And a four-armed robot, controlled entirely by that surgeon, is about to perform your procedure. Robotic surgery is being used for hysterectomies, prostatectomies, kidney removals, bowel resections, heart valve repairs, and dozens of other procedures. Hospitals spend millions on these systems, and they market them heavily to patients. But here's what nobody tells you. The robot doesn't make every surgeon better. The outcomes depend almost entirely on the person controlling it. Today, I'm giving you the 7 essential questions you must ask before you let anyone operate on you with robotic tools. These aren't questions your surgeon will volunteer answers to. You have to ask them, and you deserve honest answers. But real quick before we dive in, if you're new here, welcome. This channel is all about giving you honest, practical health information that actually helps you make better decisions for yourself and your family. We are on a mission to reach 1,000 subscribers, and every single person who joins this community genuinely matters to us. So if you find today's video helpful, please hit that subscribe button and ring the notification bell. It costs you nothing, and it means the absolute world to us. Okay, now let's really get into it. Background. What is robotic surgery? Before the questions, a quick foundation, because understanding what robotic surgery actually is changes how you think about the questions. The most widely used robotic surgery system in the world is called the Vinci surgical system, made by a company called Intuitive Surgical. As of 2024, over 9,000 of these machines are installed in hospitals worldwide. The system costs between $1.5 and $2.5 million to purchase, and that doesn't include the disposable instruments, which can add $2,000 to $3,000 per procedure. Here's how it works. The surgeon sits at a console a few feet, or sometimes across the room, from the patient. Using hand and foot controls, they manipulate robotic arms that hold miniaturized surgical instruments and a high-definition 3D camera inside the patient's body. The robot translates the surgeon's movements in real time, filtering out hand tremor and scaling down motions for precision. The advantages, when used correctly, can be significant. Smaller incisions, less blood loss, reduced pain, faster recovery, and lower risk of infection compared to open surgery. For certain procedures, in the hands of a skilled and experienced surgeon, robotic techniques genuinely do lead to better outcomes. But, and this is a big but, the robot does not operate independently. It does exactly what the surgeon tells it to do. Every move, every cut, every suture is directed by the human at the console. The robot has no decision-making capacity. It cannot sense tissue. It cannot feel resistance the way a surgeon's hand does in open surgery. This means that when robotic surgery goes wrong, and it does go wrong, it's not usually a machine malfunction. It's a human error, filtered through the machine. That's why these questions matter. You're not asking about the robot. You're asking about the person using it. Question 1. How many of this specific procedure have you performed robotically? This is the single most important question on this list, and most patients never ask it. Surgeons will often say things like, "I've done hundreds of robotic surgeries." That sounds reassuring. But you need to press further, because robotic surgery isn't one thing. A surgeon who has done 300 robotic prostatectomies and is now proposing to do your robotic sleeve gastrectomy has almost no transferable experience. The learning curve for robotic surgery is procedure-specific. Studies published in journals like the Journal of Urology and the Journal of Surgical Oncology consistently show that outcomes, complications, conversion rates, operative times, improve significantly after a surgeon has completed between 50 and 200 cases of that specific procedure. This is called the learning curve plateau, and many of the worst robotic surgery outcomes happen on patients who were operated on while the surgeon was still climbing that curve. What you want to hear. I've performed over 50 to 100 plus of this specific procedure robotic. The surgeon can give you a number without hesitation. Ideally, they can tell you their personal outcomes data for this procedure. Red flags. They give you a generic total of all robotic cases. They say something like, "I've been trained on the robot." Training is not experience. They can't tell you the number off the top of their head, or they seem evasive. Here's an analogy. Imagine you found out your airline pilot had logged 1,000 hours in a commercial jet, but only 5 hours flying the specific model of plane you're boarding. Would you feel safe? Experience with this procedure is what matters. There's a related follow-up question you should ask. How many do you perform per year currently? Volume isn't just about the past, it's about staying sharp. A surgeon who does 2 robotic hysterectomies a year is not as current as one who does 40. Surgical skill degrades with inactivity, just like any motor skill. Pro tip for this question: don't be shy. Say exactly this: I want to feel confident you've done this enough times that I'm not part of your learning curve. Can you tell me your case volume specifically for this procedure? A good surgeon will not be offended. They'll respect you for asking. A surgeon who becomes defensive or dismissive when asked this question is telling you something important. Question 2. What are your personal complication and conversion rates? Every surgery has risks. Robotic surgery is no exception. But here's what most patients don't realize. Complication rates vary enormously from surgeon to surgeon, even within the same hospital, using the same robot on similar patients. National averages and hospital statistics tell you very little about the individual surgeon who will be operating on you. You want to know their data, not the hospital's, not the national benchmark, not what the Vinci manufacturer publishes. Their personal outcomes for your procedure. 2 key metrics to ask about. 1. Complication rate. This includes everything from minor complications, urinary tract infections, minor bleeding, to major ones, organ injury, reoperation, ICU admission. Ask, in your personal experience with this procedure, what percentage of patients experience a significant complication? 2. Conversion rate. This is the rate at which a robotic procedure has to be converted to an open surgery mid-operation. Conversion isn't automatically a failure. Sometimes it's the right decision. But a high conversion rate can indicate that the surgeon is overextending their robotic approach to cases that aren't suitable for it, or that they lack the robotic skill to handle complications robotically. Ask, what percentage of your robotic cases for this procedure require conversion to open surgery? What you want to hear. The surgeon knows their numbers. They don't need to look them up. Their complication rate is at or below published benchmarks for that procedure. They discuss conversion as a safety measure, not as a failure. Red flags. Our hospital has excellent outcomes. This is not your question. The complication rate for robotic surgery is very low. Again, not your question. Any suggestion that robotic surgery is complication-free. Here's an important truth. Most surgeons in the United States are not required by law to share their personal outcomes data with patients. Many hospitals don't even track it at the individual surgeon level, but an ethical, experienced surgeon will know their numbers and will share them. If a surgeon can't or won't tell you their personal complication rate, that tells you something. Question 3. Is robotic surgery actually better for my condition, or is it just what you offer? This question makes some surgeons uncomfortable. Ask it anyway. Here is an uncomfortable reality of modern medicine. Hospitals market robotic surgery hard. They put it in their advertising, on billboards, in glossy brochures in the waiting room. Minimally invasive robotic surgery sounds impressive. It is impressive. But it is not automatically better for every condition or every patient. There are procedures for which the robotic approach has strong, well-established clinical evidence of benefit. Robotic-assisted radical prostatectomy, certain gynecological surgeries like sacrocolpopexy for pelvic organ prolapse, some kidney surgeries, and specific colorectal procedures. There are also procedures where the evidence for robotic over laparoscopic, traditional minimally invasive, or even open surgery is weak, mixed, or still emerging. Robotic surgery for some thyroid, hernia, and cardiac procedures falls into murkier territory. And here's the conflict of interest patients rarely think about. When a hospital spends $2 million on a robot, they need to justify that investment. That means doing more robotic cases. That pressure can, consciously or unconsciously, influence which surgical approach gets recommended to patients. What you want to hear. A specific, evidence-based explanation of why robotic is better for your anatomy, your condition, and your specific surgical goals. Acknowledgement that other approaches, open, laparoscopic, exist and are still valid. A willingness to discuss the trade-offs honestly. Questions to layer in. Would laparoscopic surgery give me similar outcomes? Is there any published evidence that robotic is superior for my specific condition? If you didn't have access to the robot, what approach would you recommend? That last question is particularly revealing. It strips away the tool and gets to the clinical judgment. Red flags. Robotic is just better, with no specifics. Dismissal of laparoscopic as old-fashioned. Inability to cite specific benefits for your case. You are not anti-technology for asking this. You are a patient who deserves a procedure chosen for your benefit, not for the hospital's return on investment. Question 4. Who else will be in the room, and what will they be doing? This question surprises many patients. They assume, my surgeon, means one person doing the procedure from start to finish. That assumption can be dangerously wrong. Robotic surgery has a particular vulnerability to a practice called ghost surgery, where a different surgeon, resident, or fellow completes portions of the procedure without the patient's knowledge or consent. This has led to lawsuits and disciplinary actions in the U.S., South Korea, and elsewhere. With traditional open surgery, the patient's family can sometimes verify who is in the room. With robotic surgery, the attending surgeon can hand the controls to someone else, with no visible change to anyone observing from outside the console. Additionally, robotic surgery often involves a bedside surgical assistant who handles instrument changes and assists directly at the patient's body, residents or fellows who may operate the robot for portions of the case as part of their training, proctors, experienced surgeons hired by device companies, who may guide or assist a less experienced surgeon through early cases. None of these are inherently wrong. Medical training requires practice on real patients, disclosed and consented to. Proctored cases are often safer, not less safe. But you have the right to know what to ask specifically. Will you be at the console for the entire case? Or will a resident or fellow operate for any portion? If a trainee is involved, what portions will they perform, and will you be directly supervising? Will there be a proctor or company representative present? What you want to hear: transparency, a clear, specific answer. If a trainee will participate, they frame it as a supervised learning element, not something to hide. You're right. You may consent to or decline trainee involvement. This must be documented. If you do not want a resident operating on you, say so clearly in writing before surgery. Question 5. What happens if something goes wrong mid-surgery? This is the question no one wants to ask, because asking it feels like inviting bad luck. Ask it anyway. Robotic surgery adds a layer of mechanical complexity to an already complex situation. While actual device malfunctions, the robot stopping, losing communication, instrument breakage, are relatively rare, they do happen. The FDA's MAUDE database contains thousands of reports of adverse events involving robotic surgical systems. More commonly, the complication isn't mechanical, it's clinical. Unexpected bleeding, anatomy that looks different from imaging, a finding that changes the surgical plan entirely. You need to know what your surgeon's plan is when things don't go as expected. Questions to ask. If you encounter a complication you can't manage robotically, how quickly can you convert to open surgery? And is there a qualified open surgeon available? Has your team drilled for robotic emergencies, equipment failure, sudden patient deterioration? What is the protocol if the robot malfunctions mid-procedure? This also leads to an important systems question. Is this hospital equipped to handle what robotic surgery can accidentally cause? Robotic procedures are often performed at community hospitals and ambulatory surgery centers that may not have the ICU capacity, blood bank resources, or specialist backup that a major academic medical center does. What you want to hear: a calm, specific answer. Good surgeons think about this regularly. Confirmation that open conversion is practiced and planned for, not improvised. Clear chain of command if something goes wrong. Red flag. Dismissiveness. Nothing will go wrong is not a plan. Vagueness about who is available if conversion is needed. The goal of this question isn't to frighten you, it's to confirm your surgeon has contingency thinking. The best athletes, pilots, and surgeons all share one trait. They rehearse failure so they can respond to it without panic. Question 6. Where was your robotic training and how recent is it? Not all robotic surgery training is equal, by a long measure. The standard pathway to becoming a robotic surgeon in the United States involves completing a short manufacturer-sponsored training program, often just 1 to 2 days at an intuitive surgical training center, passing a dry lab and animal lab simulation, and then performing a proctored case or two at your home hospital. That's it. There is no national board certification in robotic surgery. There is no minimum case requirement set by federal law. There is no standardized credentialing process that applies across all hospitals. Individual hospitals set their own robotic credentialing requirements, and they vary dramatically. Some hospitals require 20 proctored cases before granting independent privileges. Others require 5. Some have basically no requirements beyond the manufacturer's course. What this means for you. A surgeon can be fully credentialed in robotic surgery at their hospital, having done very little actual robotic surgery. What to ask? Where did you receive your robotic training? Was your training through a formal fellowship or through manufacturer-sponsored courses? How does this hospital credential surgeons for robotic procedures? Did you have a mentor or proctor beyond the initial manufacturer training? What to look for? Fellowship-trained surgeons, especially those who completed minimally invasive or robotic-focused fellowships, generally have substantially more structured robotic training. Surgeons who have done additional cadaveric training, simulation training, or trained under high-volume mentors have deeper skill. Surgeons who have presented their outcomes data at conferences or contributed to published research in robotic surgery are generally more invested in rigorous practice. What this question does psychologically: it signals to your surgeon that you are an informed patient. Surgeons who are confident in their training will answer proudly and specifically. Surgeons who know their training is thin may become evasive, and that evasiveness is itself informative. Question 7. Is there any financial or institutional pressure influencing this recommendation? This is the hardest question to ask. It may feel rude. It is not rude. It is essential. Healthcare is not a purely altruistic system. Surgeons are salaried employees or revenue-generating contractors of hospitals. Hospitals have invested millions in robotic systems that need to generate a return. Manufacturers like Intuitive Surgical have sales relationships with hospitals and sometimes with individual surgeons. These financial realities shape medical recommendations. Not always, not consciously, but sometimes. Research has shown that the introduction of robotic surgical systems at hospitals correlates with an increase in procedures that were previously managed conservatively or laparoscopically. Some procedures that arguably did not need surgery are now being done robotically. You are allowed to ask, is there any reason, financial, institutional, training-related, why robotic surgery is being recommended beyond it being the best option for me? You probably won't get a perfectly honest answer. Most surgeons will say no. But the act of asking changes the dynamic. It puts both of you in a position of acknowledging that this choice should be about you. Supporting questions. Does this hospital incentivize robotic procedures in any way? Through volume bonuses, metrics, or budgetary goals? Do you have any financial relationship with Intuitive Surgical or other robotic device companies? Is robotic surgery covered by my insurance for this indication? If not, who absorbs the cost difference? That last question matters. Robotic surgery is often more expensive than open or laparoscopic surgery, and some insurance plans have specific coverage rules. If a hospital is recommending a more expensive approach that isn't covered or is only partially covered, understanding who benefits financially from that recommendation is reasonable. Final thought on this question. A surgeon with integrity will not be wounded by this question. They may say, I understand why you're asking, and here's my honest answer. That kind of transparency is exactly what a trustworthy physician looks like. Let's bring this home. Robotic surgery is not a scam. It is not inherently dangerous. In the right hands, for the right patient, for the right procedure, it is a genuine advance in surgical capability. I want to be completely clear about that. But robotic surgery is a marketing category as much as it is a medical one, and the gap between the best robotic surgeons in the world and the least experienced ones operating under the same credential is enormous. You, as a patient, have the right to know where your surgeon sits on that spectrum. You have the right to understand why a particular approach is being recommended. You have the right to ask about complications, conversion rates, training backgrounds, and financial pressures, and to expect honest, specific answers. Here are your 7 questions, one more time. 1. How many of this specific procedure have you performed robotically, and how many per year currently? 2. What are your personal complication and conversion rates for this procedure? 3. Is robotic surgery genuinely better for my condition, or is it simply what you offer? 4. Who else will be in the room, and what will they be doing? 5. What is the plan if something goes wrong mid-surgery? 6. Where was your robotic training and how recent is it? 7. Is there any financial or institutional pressure influencing this recommendation? Print this list. Take it to your preoperative appointment. Don't apologize for asking. A surgeon who becomes hostile or dismissive when asked these questions is giving you important information about how they will treat you as a patient. A surgeon who answers clearly, specifically, and without defensiveness is showing you that they respect your autonomy and your life. You are not a number. You are not a case. You are a person who deserves to make an informed decision about what happens to your body. Ask the questions. If this video is useful to you, please share it with someone facing a surgery decision. Subscribe for more patient advocacy content. And if you've been through robotic surgery, positive or negative experience, share your story in the comments. Your experience might help someone watching this right now. Take care of yourselves. I'll see you in the next one.